Thank you, Dr. Natasha, for the kind
Bench to
introduction.
bedside.
Good morning, everyone. Myself, Dr. Anubhav. I am a veterinary consultant at ASDI Hospital. So I'll be talking about improving treatment adherence and treatment outcomes in cases of neovascular AMD and DME. So as for this newer molecule is concerned, we have been injecting this molecule since past 1.5 years. And having been given more than 400 injections, I would like to share how this newer molecule has helped me in my clinical practice, and would like to show some clinical experience in few of the cases too. So neovascular AMD and DME, they require sustained and effective treatments to optimize patient outcomes. But the problem with anti-VEGFs is that they have to be frequently administered for a longer period of time with the frequent relapses. So ultimately it becomes a treatment burden over the patient and the attender, and which ultimately leads to either suboptimal long-term vision outcome or the patient dropping out. And another thing is that the conventional anti-VEGFs, they don't completely address the multifactorial nature of the disease as explained by Dr. Natasha, and which includes an inflammatory component too. So I'll skip these basic things which have been brilliantly explained by Dr. Megha, and will directly jump towards the cases. So these are I'll share a few wet AMD cases and PCV cases from the treatment naive to the switch ones, and then we'll proceed towards the diabetic macular edema cases. So this gentleman, 54 years old, bilateral wet AMD patient, pseudophakic treatment naive. This was the clinical OCT. On presentation, we can see the subfoveal fluid, and the vision was 636 and 624. After being given 3 loading doses of injection Vabysmo, we can see the total resorption of macular edema and restoration of normal foveal anatomy, and the vision significantly improved to 618 and 612 respectively in both eyes. After 2 months, the patient came for follow-up, and still the OCT remained dried, and the patient was again called after 2 months. This time when the patient came, that is 4 months after the third dose, patient complained of right eye blurred vision, and we can see the relapse of macular edema in the right eye with fewer changes in the left eye too. Again, both eyes injection Vabysmo was being done, and after a month, we can see the OCT getting dried. Again, the patient came after 2 months. This means 3 months after the last injection, and this time patient complained of left eye blurred vision, and we can see the relapse of fluid in the left eye with some pockets of IRF in the right eye too. Again, both the eyes were injected with injection Vabysmo, and the next month we can see the dried up macula. So the inference is, and the patient is due for follow-up after 2 months. So total 5 injection Vabysmo are being given in both eyes of this patient in 12 months since presentation. This is another case of a 64-year-old gentleman, treatment naive case, pseudophakic, one-eyed, and we can see the right eye active type 2 CNV lesion. At presentation, the vision was 624, and we can see the SRF and the active CNV. After being given 3 loading doses of injection Vabysmo, the SRF is all gone. We can see the total drying up of OCT layers, and the vision was improved to 6.9. This patient presents after 2 months, and after 2 months we can see the small pocket of SRF creeping in. Another dose was given, and after the 4th dose of Vabysmo, 7th month and 9th months have passed, like 4 months have passed, and still the OCT is dried, and the patient is called after 2 more months. This is another case, type 2 active CNV lesion. We can see the small pocket of subfoveal SRF and the active CNV and fibrovascular PED. After 2 doses of injection Vabysmo, the lesion is all dried, and we can see the normal fovea, and the vision got significantly improved too. Now I'll switch over to the cases where I have used this molecule as a switch agent. So this patient, we can see the OCT layers. OCT looks moribund. Patient had right eye predominantly scarred active CNV case with large cystic and shitic cavities basically, and the patient was being given multiple doses since 2 years. Records were not available, and just after a dose of injection Vabysmo, it was given on 13th of February, and on 3rd of April, the OCT miraculously improved, and which was not expected, and the patient vision was also significantly improved. This is another case. This is the clinical picture. The patient was a one-eyed case. Left eye we lost due to geographic atrophy, and the right eye, it was a predominantly scarred CNV lesion. And the vision was, the patient complained of recent onset of central scotoma. We can see the submacular bleed, subfoveal, and the OCT was all disorganized. And the patient was being given injection Eylea first dose. After the first dose, we can see the clot breaking up, and the OCT structural improvement is seen. and somewhat vision got improved. Another dose was given this time, although the clot resolved, but the OCT structural changes were not significant and there was no improvement in the vision too. By this time, we were already using Vabysmo. Patient was counseled for it, and patient opted for the newer molecule. And to our surprise, just after the first injection, we can see the normal foveal anatomy is being restored, and there was a lot of structural changes in the OCT. On the other hand, in the clinical picture, we can see the amount of scarring on the posterior pole has also significantly reduced. This is one more interesting case of a 70-year-old lady, and the patient was this patient was a very wheelchair-bound patient, and patient was very treatment and follow-up compliant. She used to come every month on a wheelchair, and left eye was gone due to geographic atrophy, and right eye had a pigmented scarred CNV lesion. She came every month. She was very compliant. She was being given 15 injection Eylea right eye, and what happened was whenever we used to inject the patient with the injection Eylea, every time there was full resolution of cystic spaces, but on the very next month the fluid all used to come back, relapse. So the problem was she used to come every month to us, and it has become a treatment burden on her. So I have started collecting OCTs since 8 January 2024. After 2 injections of Eylea on March, the OCT was dried, but again the fluid came back on 11th of April. By this time, we shifted the patient to injection Vabysmo, and after the first dose, we can see the drying effect was still continued after 1 month, and on the second month, the OCT was dried. Then the patient came on 26th of July again with a relapse of fluid. Second dose was given, and again in August, September, and it is still on 12th of October, the lesion got dried. By this time, for the first time in her life, after giving injection Vabysmo 3 on 10th of November, follow-up was extended by 4 weeks, which makes a very important impact on her quality of life. And the patient came on 28th of January this time, still the lesion was dried. And when the patient came back again on 23rd of March, there was relapse of some fluid. Again, the patient was planned for injection of Vabysmo 4, and the follow-up was done after 8 weeks. Then the patient came out 2nd June. Some fluid was there, but the fovea was normal. Still, the patient was planned for injection Vabysmo 5, and the follow-up is planned for next 12 weeks. So in such cases, it has significantly improved the treatment burden. I'll share a PCV case too. This particular patient being injected with injection Razumab 1 month back, vision was 636. We can see the notch PD, large PD, and the SRF. After being given 2 doses of injection Vabysmo, we can see the beautiful flattening of PD and the resolution of submacular clot too. In the DME cases, we all know that it is marked by hyperreflective foci, and we all know that in aflibercept, as in post-hoc analysis, it is seen that it affects the hyperreflective foci in outer retina. Faricimab reduces in both inner and outer layers. So I'll be sharing a few DME cases too. This is a 58-year-old gentleman, known case of both eyes PDR, post-laser, pseudophakic chronic DME as seen in OCT. 3 doses of injection Razumab given, still not much improvement. Dex implant was done, and I agree with Dr. Megha what she has told. After that Dex implant, there was some improvement, but after 2 months, because patient belonged from a faraway place, after 2 months, it all came back. So I have to shift the patient to injection Vabysmo, and after 2 doses, we can see the beautiful collapse of the cysts, and the vision was also improved for this patient, and the vision got improved to 6/9 for the very first time. Patient is being advised for 3rd injection in this particular case and due for follow-up. Another case, right eye operated VR surgery, left eye chronic recalcitrant DME, post 3 doses of Razumab. This was OCT at presentation. After Ozurdex, after 3 months, there was not much change, and the patient was shifted to injection Vabysmo, and we can see the serial fundus pictures and the OCT, beautiful resolution of all the cystic spaces, and the vision even improved to 6/6 in this particular patient. Another 68-year-old gentleman, both eyes moderate NPDR with DME. In this particular case, after injection Vabysmo, although the subfoveal cyst is gone, but I would like to focus on the amount of hard exudates parafoveal on the posterior pole. They have been significantly reduced in the clinical picture post 2 months. Another case, similar kind of chronic recalcitrant case, multiple injections being done. After 2 doses, the cysts have collapsed and the vision was improved, and the due for the 3rd dose. So what is the impact of faricimab on ERM formation? In post-hoc analysis of Yosemite and Ryan through week 100, 8 weekly faricimab lead to a 52% reduction in risk of ERM formation versus aflibercept. So I would like to share 2 cases with a unique thing which I have seen in a few of my patients. So this particular case, the patient was a 54-year-old gentleman, high-risk PDR, post-PRP, unstable patient, multiple injections. Right eye was 660, left was 612. So in this particular patient, this was the OCT at presentation, and we can see the immature membrane lifting up the posterior pole, causing vitreomacular traction, a lot of edema submacular. So for this particular patient, the patient they want surgery, counsel for injection Vabysmo, and after first dose on injection Vabysmo, we can see the ERM component which was causing traction was it started detaching from the posterior pole, and we can see the resolution of this neurosensory detachment and resolution of fluid too. And after the second dose, the whole of the this ERM component, it was detached from the posterior pole as it was never being there, and we observed this normal foveal anatomy. So this was a beautiful case which responded with 2 injection of Vabysmo beautifully. Otherwise, it was a surgical case. This was for the other eye. And in this particular case, I would like to showcase that when the patient presented with on the right eye, we can see the macular edema and there is a ERM over it. So the normal foveal dip is not there. And in many of the cases, we see that whether we inject Orthodex or conventional anti-VEGF, although the fluid gets resolved, but the ERM component is still gives headache to us. But we can see after giving injection Vabysmo, because the onset of action is a bit slow, this ERM slowly detaches, and we can see in after one month that this ERM is in the vitreous, floating above the retinal surface. And similar happened with the left eye too. So our experience is when we are using injection Vabysmo, not to expect magic in first injection. It has a relatively slower onset in comparison to brolucizumab. It takes 1 or 2 weeks. And in the treatment naive cases of wet AMD PCV, Vabysmo is my first choice, and Eylea too. But for Vabysmo, we have to keep in mind that the initial loading is a must because it helps later in minimizing the risk of frequent early relapses and ensure 12 to 16 week extension, because it helps in disease remodeling and maintaining the vascular stability in the long run. So it can cause decrease in the DRSS score, and it causes repair of the vessels too. With Eylea, I have noticed a change that whenever we are injecting Eylea for a longer period of time, after 2 years or 3 years, there's an issue of tachyphylaxis. The patient which was beautifully responding to Eylea injection during the initial course is not responding significantly in the later time when the disease becomes recalcitrant or relapses there. And resistant to treatment is an issue with this molecule. Maybe it comes with Vabysmo, we don't know, we have to check after 3 or 4 years. Vabysmo, however, works wonderfully in such cases where there is resistant to treatment from a particular molecule like Eylea. And when we are using it as a switch in recalcitrant cases, refractory lesion, non-responders, and frequent relapses. For treatment naive DME, Vabysmo, Eylea, and Razumab, all three are first choice, Vabysmo being the first choice. Chronic recalcitrant DME, frequent relapses, and non-responders, Vabysmo is better than other anti-VEGF, but we have to keep in mind in chronic recalcitrant DME cases, multiple doses have to be explained to the patient earlier and loading needs to be done. The effect is gradual in comparison to the wet AMD counterparts. Sometimes there is miracle in recalcitrant cases of wet AMD, but in chronic recalcitrant DME, because the Ang2 level is higher from a very long time, it takes at least 3 or 4 doses of injection Vabysmo to reverse the nature of the disease. And for the DEX implant, non-responders, Vabysmo works well. Apart from that, comorbidity management, proper glycemic control, management of tractional element, like horizontal tractional element from ERM and vertical from VMT needs to be addressed. So thank you for the patient listening, and thank you so much.
Thank you, Dr. Anubhav. That was rather exhaustive. All the indications covered very well. Maybe we can take 1 or 2 questions by the time we have the next speaker, Dr. Gaurang Sehgal, with his real-world experience in faricimab. How many in the audience are currently using faricimab? Are you all practicing medical retina? Yes. What is preventing you from using it? Can I have some insight? No, but still,
Yeah, if anybody
what
has
is
a
the
doubt
major
regarding
roadblock in counseling? Sorry? The cost issue is, of course, there. But what is preventing you from counseling faricimab?
Yeah, for the costing, I like to counsel the patient that injections, whenever the patient comes to us, so it's not like we are expecting magic or nothing is going to change in the next month or next to next month. It is a long thing. We need to tell them in the very beginning that it is going to be a very long thing for you, because your diabetes doctor cannot make you diabetes negative. So the secondary complication of diabetes can never gone. It will depend on your glycemic control. So to make your vision better, we need to you need to have some injection which will make your life easy for the long term. And if the cost wise also we compare, because of the patient support programs and everything, ultimately when you take out the data of 2 years or 3 years, they ultimately spend same whether you are using injection faricimab or other molecules. So in the long run, it is same amount of monetary stress for the patient. But we need to tell them on the very first meeting only. If the in the very first meeting, if we are not telling everything in detail to the patient, then in the next time or the next to next time, they lose confidence in the doctor. For the first time, if you are explaining everything, what is going to be your future for the next 3 to 5 years, I think patient opt for this newer molecule.
Yes, you can always decide depending on the socioeconomic status of your patient. But for somebody who is reasonably well off, if you are convinced that the molecule works better, then you will be able to convince your patient better. So that is very important, the conviction. That is what we are trying to do in this session, to give you the conviction from people who have used it, that there is, especially if you have been using aflibercept, it is not the same. There is a definite difference in the results in aflibercept versus faricimab for the same indications. Dr. Anubhav, have you had a problem when you switched from aflibercept to faricimab? Did you give a washout period and did it affect your results?
Oh, ma'am, actually, the this injection, Eylea. So where I practice in Rajasthan, it is covered in Rajasthan government health scheme.
Okay,
So
so a lot of
luckily,
patients.
yeah, we are having a lot of patients, like 50 to 60 injection Eylea we are giving per month since past 5 years. And the problem with injection Eylea, I have noticed, like initially when the patients came to us being injected with injection Razumab, they have become recalcitrant, or the early relapse, they used to work beautifully when this Brolucizumab and Vabysmo was not there. Eylea was the winner for the last decade. But all those patients, when they were in third year or fourth year of their follow-up, and
It's not working so well.
it's not that good as it used to be earlier, maybe because of tachyphylaxis, and some patients have even shown no improvement or even worsening after injection Eylea. So when we are switching those patients to a newer molecule, it might be Brolucizumab, but I have switched them to faricimab. I think it works wonderfully even with a single dose. So those patients, like when we are switching the molecule, those patients are very well satisfied.
In my initial days, I found that if you give it immediately after Eylea, especially patients who've been having a lot of Eyleas, faricimab takes some time to act. If you look at the study also, they had given a washout period before they gave. But 1 month, 4 to 6 weeks washout is good enough.
Yeah.
And then it works really well.
PCV, in PCV cases, it works wonderfully.
It's very good. It
Yeah,
flattens the
even a single
PED
dose
very
works
fast.
wonderfully. Even in CRVO and BRVO cases, I have not seen improvement with other molecules. They might take 2 injections. Sometimes they take 1 injection also. Faricimab always takes 1 injection and it works wonderfully. Even in the clinical fundus picture, you can show to the patient that everything is gone. And it is also related to the studies, because when we see the amount of Ang2 levels in CRVO, it is the maximum Ang2 level, like peak is there in cases of CRVO. And
Oh. Is there a demonstrable polyp on your Octa?
Separate polyps. One is a
have you
bigger one
tried
in the.
injection faricimab in this
I
patient?
have not tried in this
Maybe you
patient.
can
I
try.
am planning to. That
Yeah,
is
Yes,
why
yes.
I
I
am
have seen in a lot of patients, even the other molecules, whether the drying effect is there, but ultimately we are losing the eye because of long-term scarring, subfoveal
Correct,
scarring,
correct, yes.
and nothing can be done for that scarring element. I have patients with injection faricimab I have been giving. The scarring is also reducing in such patient. Even one patient I have shown it at my presentation also. the scarring has reduced.
yes.
So maybe this Ang2 molecule has some role in reducing the amount of scarring and the persistent chronic inflammation. Yes, ma'am, please.
Wonderfully explained, Dr. Anubhav, and you stand up to your name, Anubhav, है ना? And I work in a very financially compromised or medical retina setup where I had to dust the OCT machine dying from before and start OCTs. So earlier, before than that, I was working in a semi-corporate sort of setup in Punjab. What I want to just know from you very briefly is the flattening in PCV compared to brolucizumab and faricimab.
Yeah, flattening is, I think, in brolucizumab because the onset of action is fast. The molecule is small, bioavailability high, it penetrates the RP very fast, and lot of drug is being injected because it is 26 kilodalton molecule, and we are injecting 6 mg. Lot of molecules they penetrate inside. So if after 7 days you do an OCT, you might get flattening better in brolucizumab and you might get nothing in faricimab. It has a relatively slower onset of action, but after a month, the result will be same. I don't have much experience with brolucizumab, few cases, but in
Wow
faricimab,
effect
I have.
maybe was more in brolucizumab.
Yeah.
Thank you.
Brolucizumab doesn't have a support program also, one problem. Second problem is the horrible vasculitis that can come in. So you really can't, especially if it's a patient who is like taking all his resources and doing it, and then you want to give him steroid, and then you want to tell
One more
him, it's a
problem
big risk.
with brolucizumab, ma'am, I've noticed is that when there is a very tall, high peaked PD and you do
RP
an
rip is
ADI-OCT and you can see some scar tissue connected to the base of that PED, and because of that rapid action of resolution, rapid drying, RP rip can
Rips
happen.
are much higher in brolucizumab,
Or
definitely.
a crunch phenomena can happen in a PDR patient when, for example, the case I've shown with faricimab, there was an immature membrane causing vitreomacular traction. I think because of that slower onset of action, gradually it got peeled by itself from the surface of the retina and the normal OCT was achieved. If had it been brolucizumab, I don't know, maybe because of the rapid contraction, there can be a combined RD.
Yeah, but having said that, any patient with traction, especially traction at the fovea, it would be better to be very careful and also advise that you may need surgery because if at all you're injecting. So any injection in a patient with vitreomacular traction is dangerous.
I have a question. Nice cases, Dr. Anubhav. So, coming to that particular case where there was foveal traction, so what made you think of using anti-VEGF as a treatment rather than surgery?
So for this particular patient, I planned for surgery. I advised the patient, but patient was hesitant for surgery. And second thing, the membrane, it was not a mature membrane, it was an immature membrane. So I discussed with my seniors from Arvind Eye Hospital, and we came to a conclusion that let's give Vabysmo, let's advise Vabysmo in such a case. And patient was a well-to-do patient, so he was kind of affording also. And we advised the patient for worsening also, but he was afraid of surgery. So first of all, we advised surgery, but he didn't opt for surgery. Then we go for injection Vabysmo,
So
and to
that
our
point
surprise,
is very important, that you should have advised surgery and then patient chooses injection knowing fully well that it might still go into surgery.
so
But in such cases, if patient is refusing surgery, giving injections can actually worsen the situation.
yeah, so but I have noticed it with this particular molecule. Another molecule would have worsened it for sure, but this particular molecule, because it is there in the other eyes also, I'm seeing that if the membrane is immature, a mature membrane, when it contracts, it can create a retinal break and the fluid can seep in inside and cause a combined RD. But in an immature membrane, because the membrane was very immature, it was not a very
There was a broad traction over
broad
the
traction,
fovea.
but that membrane
So
was
which
immature.
cases,
Thin
which
membrane.
cases would you prefer, the focal traction or the broad traction for trying Vabysmo in such
Right
cases?
now, I have not made any SOP for in which cases I'll use this molecule. But what happened with me previously in the past months, because of these few cases, 3 or 4, I have led to deduction that faricimab might be treatment option for such cases when there is a vitreomacular traction with an immature membrane because of its slower onset of action, because gradually it separates from the surface of the retina and we might get better results. And it's yet to be study proven.
Definitely we need
Publish
more
it
evidence.
and then we'll talk about it in this regard later.
Sir, I have a very good experience with this VMT immature membrane. I sent the patient to the PG Chandigarh for the vitrectomy, but they sent back the patient to me for giving the injection, 3 injections. I gave the 2 injections with ranibizumab. The membrane got separated from the fovea and foveal edema suppressed, and patient got the visual acuity 6.
Yeah.
So generally, any intravitreal injection will induce a PVD, and that induction of PVD can, if you and the patient are lucky enough, can detach from the fovea and the fovea contour is maintained. But the problem is that you can also land in trouble when you get a partial thickness hole or you get a full thickness hole or a TRD. So it is you have to use it very judiciously. Use your clinical judgment,
Yeah,
look at the
risk
OCT
of,
thickness,
worsening
see
is
how
much higher.
how much traction is there. Is it an epiretinal membrane component more than a VMT? And then decide whether you want to inject or not. I think we will go to the next speaker. Yes, sir.
Sorry, sir, multiple
PEDs. Drusen.
drusenioid PEDs. No, I don't use, sir, in such cases.
Patient is having 6 vision,
Yes, sir.
sparing the this foveolar region.
Yes, sir.
Should we give the this anti-wave to the patient or not?
No, sir. I
Do
don't
you
use
have
in such
do you have any angiographic evidence of
sir,
a subclinical CNVM?
Sir, whenever the patient comes now, first thing is patient should be symptomatic, because if the patient is not symptomatic and I'm advising a costly molecule, I don't think I'll be justifying the effect after a month, because he will not appreciate anything. So first thing is patient should be in trouble and he should be the first one to ask me that I have this problem, please give me a solution. And when patient is coming and he is asymptomatic and I found something like what you said, I can explain the patient that you have such problem in your scan. Right now you are asymptomatic. We will have a close look and observation. It might worsen. If it get worsen, we have a lot of things to make you better. But right now you are asymptomatic. There is no logic in I think injecting or doing something.
You mean to say we should wait for the things to worsen?
We have to keep the patient in close observation.